The title of my talk today are techniques to reduce rectal dose in the radiation management of prostate cancer. I have no financial disclosures to make. What I'd first like to discuss is rectal dose volume relationships, the effective dose on rectal bleeding. So this is one of the first studies specifically to brachytherapy that looked at the effect of the dose given off by the prostate and the seeds to the rectum, and that relationship to developing what we call grade 2 proctitis, or we defined it as rectal bleeding. This is a paper we wrote in 2001. We looked at our iodine-125 implants and measured the dose delivered to the rectum, and then created dose volume histograms for each patient, and looked at amount of rectal tissue receiving the prescription dose and its relationship to developing this grade 2 proctitis rate. Our endpoint was 5-year actual grade 2 proctitis rate. And so what we found that for various doses given off by an I-125 implant, there were various cut points above which the patient was much more likely to develop rectal bleeding. Below, they were much less likely, and all those cut points were statistically significant. Now, for us, our prescription dose for I-125 was 160 gray, and we found the most significant cut point being 1.3 cc's of rectal tissue from the dose volume histogram. Above that, there was a higher likelihood of developing proctitis, and below that, it was much less likely to develop proctitis. And so when we divided our patients based on the 1.3 cc cut point on their dose volume histogram, we had 90 patients less than 1.3 cc's and 122 patients greater than 1.3 cc's. And if you had less than 1.3 cc's, the likelihood to develop bleeding was less than 5%. But if you had more than 1.3 cc's of rectum receiving the prescription dose, you were closer to about 20–25% likelihood of developing grade 2 proctitis. So we clearly established that there was a relationship, and that the more dose, the more volume of rectum receiving dose, the more likely a patient was to develop radiation proctitis. So this basically looks at the various doses given off by the prostate implant and the various cut points, as I mentioned, that were used. And you can see, which makes sense, is that the lower the dose given off, the higher the cut point. And so you can see the 160 is at about 1.3. For very high doses, the cut point for developing proctitis was under 0.5 cc's. And this basically shows that it was as the amount of rectal tissue receiving the prescription dose increased, so did the risk for proctitis. So you can see if it was less than 0.8 cc's, it had almost zero likelihood of developing proctitis. But as it climbed up to 0.8 to 1.3, again, you're around 5 to 7%. And then 1.3 to 1.8, it goes up. But after 1.8, it really goes up quite high. So you're dealing with close to 25% once you get to greater volumes of tissue receiving the prescription dose. So other people subsequent to that also found relationships between brachytherapy dose to the rectum developing morbidity. This is a paper from Frank Waterman, and instead of looking at the amount of rectal tissue, they looked at the percent of the rectal surface that received a given dose. And they had 10 patients that developed rectal morbidity, and as you can see, those patients had a higher percentage of rectal surface area compared to the larger percentage of patients who did not develop any rectal morbidity, who had lower surface doses. This is another graph from their presentation, again, showing that those patients that had rectal morbidity at various dose levels given off by the implant had a greater percentage of rectal surface area covered by those given doses as compared to those that did not have any morbidity. They had lower doses. This is a subsequent paper written by the people at Dana-Farber and the Brigham and Anthony D'Amico, looking at their implants. They used a cut point of 8 cc's, getting 100 gray. So what you can see here is that ACCs are more of rectum getting over the 100 gray, basically had about a 20% likelihood of developing radiation proctitis versus no patient who had less than 8 cc's receiving the 100 gray of the implant. This is another paper from Memorial Sloan Kettering Cancer Center looking at their implants, also finding a dose volume relationship. They used a cut point of 2.5 cc's and found that if the prescription dose was less than 2.5 cc's, you could see it about 40% of the patients developing grade 2 proctitis. But if the prescription dose goes to greater than 2.5 cc's, it's, the number of patients getting proctitis is much greater. So you can see the much higher bar of the R100 in patients that had greater than 2.5 cc's receiving the prescription dose. And this slide shows an interesting phenomenon, which can relate to one of the things I'll be talking about today, which is using a hydrogel spacer. It was a very interesting paper that basically said it depends on when you look at the implant and do what we call post-implant dosimetry, that will have an influence on the dose to the rectum. And what it showed, if you look at the two top graphs on the left and right, is this is dosimetry that is done one day after the actual implant. And because there's associated edema with that, there is a space between the prostate and the rectum that you can see. And the dose from the prostate rarely goes to the rectum. But if you wait 1 month, do that same CT, the same implant, you will see that that edema has resolved. The prostate has gotten closer to the rectum, and hence the dose to the rectum is going to be great. So for the purposes of what we're doing, certainly one of the things that I'll talk about that people are doing is to do the implant and then to put something like a hydrogel spacer right after the implant so that you keep that distance. And because the hydrogel spacer will stay for 6 months, you're going to avoid that phenomena where the prostate kind of gets close to the rectum, because it'll always be kept physically apart from the rectum because of the hydrogel spacer. And this slide demonstrates that, kind of looking at the amount of cc's of rectum receiving the RV100, or that's the dose, the prescription dose. And you can see at day 1, it's very low because of the edema, but by day 8, it's going up. And by day 30, because the edema has resolved, the dose to the rectum is higher. This was a large series from Memorial Sloan Kettering Cancer Center titled Late Rectal Bleeding After Conformal Radiotherapy of the Prostate, Volume Effects and Dose Volume Histogram. And again, showing that kind of same phenomena where patients that develop rectal bleeding were more likely to have greater percentage of the rectum receiving various doses, while patients that did not bleed was the lower curve. So for any given dose, there was basically a smaller portion of the rectum receiving that. So clearly, if you can reduce the dose to the rectum, you will reduce rectal bleeding. So what are the ways that we can try to do that? Well, one of the earlier efforts was by using something called rectal balloons. Now, the rectal balloons would be something that you place in the rectum, would blow up, so it would inflate it. And essentially, though, it would do two things. It would push the anterior rectal wall close to the rectum, but by expanding the rectum, it would push the more posterior portions of the rectum by expanding it away from the radiation beam, either from external beam or from an implant, if that's part of the course. And what you can see from this slide is they tested 3 different endorectal balloons, 1, 2, and 3 versus none. And you can see for any given dose of radiation, there's less rectum fraction. It's called the fractional inner rectal wall. So there's less of the rectum being treated because you're taking the posterior portion of the rectum, inflating it with the balloon and pushing it away from the radiation. So here's an example of what it looks like. So the slide on the left is with the rectal balloon. So you can see it's filled up with either, usually with water or air. And you can see that the anterior rectal wall is right up against the prostate, but the more mid and posterior parts of the rectum are clearly away from the dose. And you compare that to those patients without a rectal balloon, and even though the amount of rectum getting, let's say, the high dose may be the same, the lower doses clearly occupy larger portions of the rectum if you're not using the rectal ball compared to when you do use a rectal balloon. Again, from this study, you can see those patients with rectal balloon, curve A, and B, patients without a rectal balloon, and the y-axis, the ratio of the total structure of the volume versus any dose. So with any given relative dose, if you look at 80% of the dose, it's occupying a greater percentage of the rectum without the balloon, curve B, compared to curve A with the rectal balloon. The title of this is Reduced Late Rectal Mucosal Changes After Prostate Three-Dimensional Conformal Radiotherapy with Endorectal Balloon is Observed in Repeated Endoscopy. So this is looking at endoscopy noted mucosal changes as opposed to looking at rectal bleeding. There was a T1 score and a T2 to 3 score that was rated by the endoscopist. The same thing if you are not using a rectal balloon compared to using a rectal balloon at various endpoints, you're getting more changes without the rectal balloon. That's the white, more changes in the mucosal surface as measured by endoscopy. Then when you do use it, you reduce that amount of mucosal changes. That's both in the T1 and the T2 to 3 score. The title of this paper is Reduced Late Rectal Mucosal Changes After Prostate 3D Conformal Radiotherapy with an Endorectal Balloon in Repeat Endoscopies. So again, this is looking at, again, mucosal changes, and you can see when they map this out of the amount of mucosal changes without a rectal balloon, whereas with a rectal balloon, you can see this, especially if you look at the sagittal images, that when you have a rectal balloon in place, because you are displacing the posterior part of the rectum, you're getting less mucosal changes. So clearly you are sparing, but as I said, one of the potential pitfalls of using the rectal balloon is you're not really changing the anterior rectal portion in terms of mucosal changes or rectal bleeding with or without the rectal balloon. Okay, the title of this paper, which was published in 2014, is Absorbable Hydrogel Spacer Used in Men Undergoing Prostate Cancer Radiotherapy, 12-month toxicity and proctoscopy results of a prospective multi-center phase 2 trial. And here's just a diagram kind of showing the hydrogel spacer in the image on the right, and you can see how it displaces the prostate away from the rectum compared to not using it in A, and hence the dose that you want is the prescription dose may not even touch the rectum, while it will definitely deliver dose to the anterior portion without the hydrogel spacer. So here's the results, and it's comparison of what's called the Vienna rectoscopy scores at 12 months for men treated with SpaceOAR versus a series from the literature. So the blue is a series from the literature, the red is the SpaceOAR. So if you look at these Vienna rectoscopy scores, the low scores mean very little change versus the higher scores more change, is that you can see using the SpaceOAR have a greater percentage of patients with the 0 to 1 compared to, let's say, the literature review where the scores tend to be higher in the 2 to 3 range. In terms of telangiectasia, the same concept is that you're getting more with nothing in the blue lines. When you're not using a hydrogel spacer, you're getting a higher telangiectasia scores than you would when you're using SpaceOAR. And in terms of congested mucosa, the same thing. If you just focus on the red, you see that almost everyone is at score 0 congested mucosa, and maybe one patient has congested mucosa too. So clearly using that SpaceOAR versus just a literature review shows a reduction in radiation effects by using endoscopy. This is a study published in 2015 comparing two different rectal spacers in prostate cancer external beam radiation in terms of rectal sparing and volume consistency. And again, this is looking at a biodegradable balloon versus using a hydrogel spacer versus a control group. And you can see just in terms of absolute dose surface histogram of the rectum, comparing these three different types of treatments, you're getting more surface area if you're not using a biodegradable balloon or the hydrogel spacer, and that's the black line in the graph on the right. And you can see the various A, B, and C, C being the balloon, and you can see the difference. I'm sorry, C being the control group, A being the gel, the balloon, and B being the hydrogel spacer. So as you can see, by putting some kind of physical, something physical between the prostate and the rectum, you will displace it away from the rectum, hence less dose to the rectum. The title of this in 2007 is Transperineal Injection of Hyaluronic Acid in the anterior perirectal fat to decrease rectal toxicity from radiation delivered with IMRT. And here's just a nice MRI showing you what it looks like on the left without the hydrogel spacer. And you can see that white oblong shape, which is the hydrogel spacer displacing the prostate away from the rectum. Here's just an illustration of how this is done. It's done transperineally. The ultrasound probe is used to image, but we reduce the amount of fluid in the probe so that we can kind of open up the space between Denonvier's fascia and the rectal wall. And then we use water to hydrodissect that space. Once we know we're in the right space, we put in the hydrogel spacer, and it basically separates the prostate from the rectal wall. And this can stay in place for at least 6 months. So this is a multi-institutional clinical trial of rectal dose reduction via injection of the hydrogel spacer for IMRT analysis of dosimetric outcomes. This was, you can see here in figure 1, what you have on the left is MRI images of a patient before the hydrogel injection, after radiotherapy in the middle, and 6 months after injection. So this really goes to show you how, again, the SpaceOAR in white displaces the prostate away from the rectum and protects the rectum, and also how it does resolve within 6 months. So it's very important to know this when you tell patients this won't be in you forever, and it resolves within 6 months. Here's another application of an interstitial and biodegradable balloon system, again, to spare rectum from radiation dose, and this shows you an implantable rectal balloon. This slide, again, is part of a randomized trial that was run, dosimetric and clinical effects of perirectal spacer application in men undergoing IMRT radiation therapy using SpaceOAR. This was a key paper from multiple institutions that really demonstrate how the SpaceOAR, you can see from the rectal DVH data, markedly reduces the dose to the rectum while giving external beam radiation therapy. If you look at the graph on the right, the patient rectal V70 dose reduction, you can see that's reduced there with the use of the SpaceOAR. Same thing, rectal DVH, the control versus the SpaceOAR, showing reduction in rectal dose with the use of SpaceOAR. And this kind of paved the way for the widespread use of this, especially in the external beam treatment, that it can be done. And then when it is done, you get much better dose symmetry. And hence, from other studies that I've showed you, reduce rectal bleeding will come from that. Again, this is another absorbable hydrogel spacer used in prostate radiotherapy, a comprehensive review of phase 3 clinical trials published to date. Again, if you kind of look through all this data, it just again shows reduction in rectal toxicity with the use of a hydrogel spacer or whatever, and these are multiple endpoints that are being used. And you can see the significant ones are late grade 1, grade 2 rectal toxicity is reduced. And urinary incontinence is reduced, rectal pain is reduced. So again, this is now translating. First, we've seen that it reduces the amount of dose to the rectum, and this study shows us that it reduces the clinical toxicity associated with radiation proctitis. This is a prospective analysis of a hydrogel spacer for prostate cancer patients from Australia. There were 76 patients with clinical stage T1 to T3 prostate cancer who had the perirectal spacer placed prior to IMRT. There were no postoperative complications from doing this, and the mean prostate size was 60 cc's. Just some schematics from this paper. Again, just giving you an idea of what it looks like to have the SpaceOAR in place, the hydrogel, and how it displaces the prostate away from the rectum. And again, by doing this, you can see on figure 2, how let's say the 78 gray line, which without the SpaceOAR is covering part of the rectum and completely not covering the rectum once you put your hydrogel spacer in place. And these are the mean rectal volume constraints for different prostate sizes in this phase 2 trial. And obviously, the larger the prostate, the more rectum you're going to get. And figure 4 shows acute GI toxicity by time frame. And so you really have mostly with SpaceOAR in place, no toxicity at all, a very small amount of grade 1 and no real grade 2 or 3 toxicity when SpaceOAR is in place. So this is one of the first papers to look at using the hydrogel spacer in relationship to prostate brachytherapy. And in this particular trial, the palladium implant was done, and then the spacer was placed at the time of the operation. So this kind of looks at all the aspects of kind of doing this, in a trial. And this was published from the Memorial Group. And the picture here using MRI, again, shows on B, you can see in a transverse image, an MRI of the prostate. You can see the seeds in place, and the white represents the hydrogel spacer, just pushing it away from the rectum. You can see that on sagittal as well. You see the prostate, and then the hydrogel spacer in white separating it from the rectum. In terms of the acute GI and rectal toxicity, they compared the SpaceOAR patients to a matched control group. And there were patients that got implants alone or implant and external beam. But if you just look at the comparisons, you can see that without the SpaceOAR, you have a much higher incidence of diarrhea versus the SpaceOAR cohort. And that's with implant alone or implant and external beam. In terms of rectal discomfort, there was more rectal discomfort in the SpaceOAR patients, which makes sense because we are putting something in there, and there was none in the control cohort. But in terms of significant issues, and the reason we use it is in the SpaceOAR cohort, there was no no rectal bleeding in an implant alone, and 5% the implant and external beam. When you looked at the other cohort, it was almost 7% with an implant alone and close to 20% without using the SpaceOAR, so a significant difference. And in terms of the definition of proctitis, again, no proctitis in the SpaceOAR cohort. And in the matched control group, there was about a 5.5% with implant and external beam. So this is one of the first papers showing that this can be used after a seed implant. And just like with external beam, it does reduce dose to the rectum and hence rectal toxicity. And finally, I'd like to end on a paper we recently published here at Mount Sinai. And this came up because I had been referred a patient who had undergone a hydrogel SpaceOAR placement in anticipation of getting external beam radiation therapy. And then the patient changed his mind and wanted to have a seed implant. So my concern was that the SpaceOAR would create some ultrasound artifact and make it impossible to actually do the implant. And so first I had the patient undergo ultrasound with his urologist, who told me that he could clearly see through the SpaceOAR based on its material and had good imaging of the prostate. He felt it was safe for us to go forward. We did that patient, and indeed we did find that we could see right through the hydrogel spacer and able to do the implant. So we began to treat patients, many of them with combinations of SBRT-like radiation regimens of 500 times 5 and a palladium-103 implant. But before we did anything, we did the SpaceOAR. So the point of the study was to basically look at, did the SpaceOAR interfere at all with our ability to do a prostate implant properly by looking at dosimetric values from the post-implant dosimetry, and did it reduce the dose to the rectum? So we had a total of 168 patients who met our criteria. 22 had received this hydrogel SpaceOAR prior to receiving any treatment, and the other ones were matched control groups. And this was the result. So this is what it looks like. If you look at image A, you can see the prostate. The needles are in place, but that black, dark black is the SpaceOAR, and then the blue outlines the rectum. So again, you can see how the SpaceOAR done first prior to the external beam, and then the patient's brought for the seed implant. And then we do it. So what we notice, if we just were looking at the D90 of the prostate over 100 gray, there was no significant difference between those that got SpaceOAR and those did not, demonstrating that you could feasibly do an implant as well with the SpaceOAR in place and without. The V100 of the rectum was with no SpaceOAR, 85% versus SpaceOAR 100%. The V100 of the prostate was no significant difference. But again, one of the key things is we looked at the V100 of the rectum and CCs, again, based on that very first paper that I showed you, was that with no spacer, the amount of tissue was in CCs 0.17. So it was still quite low. But with the SpaceOAR, it was much lower, 0.09, and that was statistically significant. So the SpaceOAR did, in the implant itself, markedly reduce the dose to the rectum. So I think, in summary, SpaceOAR is here to stay. There may be other products developed in the near future that may be just as good, but it definitely does reduce dose to the rectum, and hence rectal toxicity. It can be done with the seed implant, both before the seed implant, and our study kind of paves the way that you can do this. We are currently instituting a phase 2 trial to test this, but this anecdotal evidence does show us that we can do it. As well, it can be used after an implant also to reduce rectal toxicity. Thank you.